Non-trauma fractures. Published by WordPress.com. Stress fractures and related conditions. 1. Stress fractures, femoral neck, shaft, tibial shaft. Epidemiology. Common in runners, military recruits, and athletes. Femoral neck fractures are typically caused by repetitive loading. Pathology. Repetitive loading causes microscopic fractures, crack initiation. Continued loading prevents healing, leading to stress fractures, crack propagation. Classification. Compression side. Often involves the femoral neck. Tension side. Common in the femoral shaft and tibia. Clinical presentation. Pain in the anterior thigh or groin. Leg pain with weight bearing. Later findings may include linear lucency and cortical changes. Imaging. X-ray. Initial imaging, often normal in early stages. CT, MRI. Sensitive and specific for diagnosis. Detects early changes. Bone scan. Good sensitivity but poor specificity for stress fractures. Treatment. Conservative, non-weight bearing, NWB, rest. Operative. Internal fixation, ILN. ORIF with percutaneous screw fixation for tension side fractures, fractures with fatigue line greater than 50% femoral neck width. Other sites for stress fractures, ribs, olecranon, march fractures, second metatarsal, and fusiform callus formation around transverse fractures. 2. Exertional compartment syndrome. Definition. A condition characterized by reversible ischemia to muscles within a compartment, primarily affecting the anterior leg compartment. Epidemiology. More common in males, third decade of life, especially among runners. Pathology. Compartment pressure rises due to insufficient clearance of metabolic waste products. Possible fascial defects or hernias contribute. Clinical presentation. Pain, aching, or burning in the affected leg, typically worse with exercise and relieved by rest. Paresthesia over the dorsum of the foot and decreased sensation in the first web space. Imaging. MRI. Can show muscle deoxygenation, near-infrared spectroscopy. Compartment pressure measurement. Resting pressure greater than 15 mm of mercury, post-exercise pressure greater than 30 mm of mercury. Treatment. Conservative, activity modification, NSAIDs, physiotherapy. Operative. Fasciotomy, deep posterior compartment or two-incision technique, in severe cases. 3. Tibial stress injuries. Tibial stress syndrome and fracture. Epidemiology. Overuse or repetitive load injury in runners, especially in the tibial region. Pathology. Medial, posteromedial, and anterior, anterolateral, tibial stress syndromes caused by traction periostitis. Clinical presentation. Vague, diffuse pain along the distal tibia that increases with running. Pain worsens with exercise and may be relieved by rest, early stage. Decreased sensation over the dorsum of the foot, particularly in the first web space. Imaging. X-ray. May appear normal in early stages. MRI. Shows periosteal exostosis in later stages. Of choice. Bone scan. Useful for detecting stress fractures. Treatment. Conservative, activity modification, NSAIDs, physiotherapy. Operative. In severe cases or when conservative treatment fails, a fasciotomy or periosteal release may be necessary.